Welcome to Muted in Medicine, the podcast where we break the silence on the untold stories and pressing issues within the healthcare professional. Join us as we dive deep into topics that often linger in the shadows of medical corridors and are not discussed in conferences, meetings, social gatherings, and in the hallways. They are often hiding. From navigating errors and facing litigation to the often overlooked realm of mental health among healthcare professionals. Through candid conversations and storytelling, we aim to amplify the voices and shed light on challenges that resonate across the medical landscape. So grab your stethoscope and a cup of coffee and tune in as we uncover the layers of complexity in the world of healthcare that are so muted, yet so profoundly impactful.
Hello, everyone, and welcome back to Muted in Medicine, the podcast where we break the silence on untold stories in healthcare. My name is Saba Fatima, and I'm your host for this podcast. I'm a pediatrician with a passion for helping healthcare professionals facing secondary trauma at work in healthcare, which often they are unprepared to face. If you're liking our content, please subscribe to our YouTube channel and give us a review on Apple or Spotify. We spend years learning how to treat disease, but very little time learning how to change the systems that cause it. As physicians, we witness the cracks in healthcare every day, families falling through the gaps, patients waiting for care, colleagues burning out, and yet for many of us, advocacy feels like something other people do. Lobbyists, policymakers, administrators, not doctors. But what if the most powerful voices for change are the ones who see the system from the inside? In this episode, I talk with Dr. Jennifer Cowart, a physician advocate who reminds us that speaking up is not politics, it's patient care. We explore why advocacy matters, what holds physicians back, and how finding your voice can be an act of healing in itself. Dr. Jennifer Cowart is a practicing academic hospitalist and associate professor of medicine. She has more than 10 years of experience in patient safety and quality improvement, which led her to develop an interest in healthcare policy and legislative advocacy. She has served on policy committees for Society of Hospital Medicine and Society of General Internal Medicine. Her opinions expressed here are her own and not representative of her employer nor any medical society of which she's a member. Dr. Cowart, welcome to the show.
Thank you so much, Dr. Fatima. It's a pleasure to be here.
We ask everybody when we start, what's bringing you joy in medicine today?
It's still really exciting to have deep conversations with patients and feel like I have either made a clinical difference or that my connecting with them has been special or gone above and beyond. So I was just on service recently. I had a couple of interactions that I felt like were really special. And even when other things are hard, I take those special interactions with me and think I feel like I really made a difference here.
Yeah. And so much of medicine is now paperwork and, but still when I talk to clinicians here, I think that's the most important piece for them, just patient care. So going into the topic, what first drew you into advocacy and, how do you define that as a physician?
So I used to, before I got involved with this work, I really didn't see this as something that was for me. It was not something I really followed the news around, but I started to study quality improvement. And part of the study of quality improvement involves systems thinking. So you start thinking about a clinic or a nursing unit, and then the regional system there, the hospital system there, maybe the hospital system that's larger than your individual institution, and start thinking about these as systems and structures that you could potentially intervene upon. So eventually you start thinking, well, what's the even bigger system other than my hospital where I could do little quality improvement projects? Well, here's the healthcare system, either locally, state, or federal. So I think it really was born from my initial interest in training in quality improvement, just seeing it as one more system. Advocacy, I think, is defined very broadly, and the ACGME also defines it really as, kind of taking action for patients' needs. So advocacy can also be any small action on behalf of one patient, advocating for one patient's care, all the way up to, again, advocating for larger change at the system level. And so I think keeping a broad lens on that is really important. Some people get really focused on thinking, well, if I'm not at the state capitol or at the US Capitol directly talking to lawmakers, then I am not advocating. But actually, I think we are advocates all the time. Pediatricians, I think, really do this very well. And adult medicine, I think, should catch up a little bit to the pediatricians. So
Yeah.
I would just keep advocacy at a broad scale. If you can speak up on behalf of a single patient, you can speak up on behalf of more than one.
Yeah. And I think a lot of physicians hesitate to engage in advocacy. They're scared. And I don't know. And they're bad at advocating for themselves too, like really bad, but also for patients in general. So I think, are they afraid of being too political? Like, what do you think goes behind that?
Yeah, there's a lot that goes into it. Yes, definitely doctors are afraid of seeming political, especially at a time of, high partisan divide. People are worried about saying something that's going to put them over a line one way or the other with colleagues or with patients. So that's, I think, really driving people a lot of times not to speak up. But there's also people are busy. And so they feel like, well, that's somebody else is going to take care of that. I'm busy. I need to take care of my patients. I have clinic, I have rounds, et cetera. And then there's also a lack of training. So I think when you dive into more some of these other reasons and rationales for not taking action, at base for a lot of it is discomfort. It's feeling like I don't know how. I don't know how to speak up. I don't know enough about Medicare policy and the specific laws to feel like I can confidently talk to a lawmaker about something that's affecting my patients in Medicare. So, my hope is that we can bring more people into this space by showing them that your voice matters, that you don't have to be an expert in specific laws to get started, and that it is our lane, that this is our space. If we can educate and advocate for, again, the patient right in front of us, then why should we not use that voice to advocate for larger numbers of patients?
Yeah, at some level, do you think it feels like disheartening too? Like, we're doing this, you're not seeing any change. You keep doing this. Do you feel that too? And you're like, I don't want to do this anymore with that sense.
Yeah, it does get disheartening at times. I mean, um, for but we have to kind of to keep going. You have to try to take the wins where you can get them because change is hard. Uh, and so if you think about a small project at your hospital, a lot of times it takes a long time to do research projects. We'll take a hospitalist fellow and we'll tell them they have 1 year and they're supposed to do all these projects. So they come in with this big, huge, grand idea. They're going to fix readmissions. And then we tell them you have 12 months to do your project and your clinical work and apply for a job and get your project completely finished, all the data collected and written up. So you go from I'm going to solve readmissions to how about I do this very small project on this one unit where we improve SCD use and documentation. You narrow down your focus to try to get something that you can get across the finish line. So I think when I feel a little burned out on policy, or I think, wow, there's a lot of things happening, and I wish I could help more patients. I could help more patients who are uninsured. I could help more patients who can't afford their care. I try to remember the times where we did have a big win or really did something meaningful and try to use that to help remind me to keep going. So, one of the fights that I felt like was really valuable was buprenorphine expansion for folks with opioid use disorder and banning the X waiver or X waiver movement, as that was called. So, I used to be one of the only buprenorphine X waivered physicians in my organization and developed a little expertise in how to manage some of those patients. And it was a real win when that did pass into law a few years ago. And suddenly you don't have to go apply and take many hours of training to update your DEA to prescribe buprenorphine. Suddenly everybody can prescribe buprenorphine. And now we're advocating for other physicians and providers to get that training and expertise so that because it's not anymore just the wheelhouse of a few specialists somewhere. This is everyone's wheelhouse because guess what? Anybody can have opioid use disorder and we're all responsible for their care. So I just try to think when I'm feeling a little burned out, I either take a little break if I need a break, or just try to remind myself of some of the things that we've had wins on, and then try to find that strength and energy to keep going.
Yeah, that's awesome. Yeah, and I guess if you keep doing it long enough, you will find some wins and some losses on the way, right? You said, advocacy can be very small, at one single patient level. So what does advocacy look like? I would say like a local, state or federal level, like for someone who's just thinking about it and feels overwhelmed with this concept.
hmm Yeah. So if you think hyper local, think about the way that we get started in quality improvement is to say think of something that really bugs you on the day to day and try to solve it. So one of the QI projects I did in the last couple years, I feel like has that advocacy flair or feel. One of my patients that I was rounding on, I saw right after dialysis, and he was eating breakfast. I said, "How's your breakfast?" And he kind of got a little grumpy with me and said, "It's cold and it's awful." And I said, "I'm so sorry. I'm so sorry. Let me try to help you with that." So I go to ask, "Why is this gentleman's breakfast cold?" And I'm told, "Well, we have a major mismatch in the timing between early dialysis and the timing of early breakfast trays." And we turned that into a QI project. It was not in time to help the specific patient in front of me with the cold breakfast, but we turned into a whole huge project to try to feed our patients. And it was because one person said something and it helped us become aware of a bigger problem. So I think at your hospital level, looking at your hospital policies, looking at things that could be changed, just calling attention to a problem that you or your colleagues or your patients or your nurses are facing is really important. At the local level, there's actually quite a bit that can be done. So, I was recently living in Florida, and our city council and our mayor's office became very interested in health policy and what they could do at the local level to improve population health. And so I actually brought some of my residents to meet the chief health officer for the city. We looked at their plans. They were really deeply engaged in looking at food deserts and areas of poverty, wanting to create telemedicine services so that folks in these underserved areas, if they were thinking about going to the ER, but they weren't sure, they could call a free telemedicine service and get a quick consult, and then they would guide them, yes, you need to go to the ER, or no, and then they would hook them up with one of our free clinics in the area. And so learning what they could do to help patients, even in a place that didn't have Medicaid expansion, it was really important. I also advised on a committee for the city that really tried to engage uninsured patients with ACA plans, to try to ensure that they could get access to insurance, and move out of the uninsured status, move into an insured status with a plan that they could afford. They were hooked up with a plan that they could afford, and trying to make sure then that they had insurance and could actually access care. So at the local level, engaging with your city council, engaging with your mayor's office, engaging with your health department. There's things that you can do even in a place where public health dollars may be cut, or a state that didn't expand Medicaid. There's still things you can do. So then at the federal level, this is where everybody kind of thinks of in terms of policy. But remember, you don't have to go all the way this high in order to be an advocate. But if you want
Yeah.
to, specialty societies for clinicians are a great place to start. So again, not speaking on behalf of these organizations, but I know a couple that I have belonged to that have helped me along this journey would be Society of General Internal Medicine and Society of Hospital Medicine. So just shouting them out. But again, pretty much any of your major medical societies are going to have advocacy days. So they'll call it a Hill Day or an advocacy day. You sign up, you travel to DC, and they'll give you a little briefing beforehand and say, these are the items that we want to talk about. And then they'll set you up with meetings with your lawmakers. So these are the folks in your state, in your district. You are their constituent, you are their voter. Whether you voted for them or not, it doesn't matter. They represent you. And so you can go into those meetings. It's either there's the legislator themselves or a staffer. It's often a staffer. And you go in and you introduce yourself and you say, "Hi, I'm Dr. Cowart. I work as a hospitalist at blank hospital in your district, and I want to talk to you today about a couple issues facing our patients." And then you keep it pretty tight. You don't try to boil the ocean. Usually they'll brief you really well, so you have a handout that you come in with, and you'll say, we want to talk about observation status and how it's impacting our patients. and their ability to get into skilled nursing facility care for rehab. And let me tell you about a patient that I just had, and she had back pain. And you walk through a story, and we are storytellers in medicine. And so you use that story. And then if they have a specific question about the policy that you don't know the answer to, we're also really good at saying, I don't have that right in front of me, but let me look it up and I'll get back to you, right? We practice this before we see our patients. So
Yeah.
it's the same when we see the lawmakers. And then we email with that lawmaker or staffer afterwards to close the loop, give them the information they're asking for, try to help with that. So it seems really scary before the first time you do it. You think, "Oh no, I'm not a lawyer, I'm not a policy expert." After you've done it a couple times and you realize that's not what they want. They don't want you to be a policy expert. They want you to be a doctor or a provider or healthcare clinician. They want you to speak with that voice and tell them what's going on with your patients and tell them what's going on with hospitals or clinics in their district or their state, and how the impacts of policies that they are passing are going to impact everyone. So I would say start small if you've never done it before. If you're interested in joining in federal policy advocacy, join a specialty society's Hill Day. And that is such a great way to start. They will prepare you, they guide you through it, hold your hand, and it's much less scary when you go as a group.
Have you felt when you were out there, doing the advocacy and talking to lawmakers or staffers, do you feel like they're engaged or you're making like a meaningful difference or you've seen the impact of it, or is it's just like, I have to get through this. I'm curious. Yeah.
It can be a little of both. I've certainly had some meetings that felt more productive than others. But for the most part, the staffers that you're meeting with are young and enthusiastic. And they're working in DC because they want to change things. They want to make things better. So I have generally found that the meetings themselves, more often than not, are very pleasant. They're kind of fun. You're meeting new people. They will ask questions that you weren't expecting, so you have to think on your feet. It's really good to have a partner when you're there and have somebody else in the room because you can tag teams. Somebody has a really good story about law X. So, hey, Dr. So and so, I hope you were willing to share your story today and tag in your buddy.
Mhm.
Um, Occasionally, you'll get a meeting that doesn't feel so productive. The person seems checked out and they don't, they're kind of nodding like, okay, yeah, 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 but, I mean, we all have days like that, so I tend to be forgiving and just say, "Okay, that wasn't that person's day." Um, Even people who I might not otherwise politically agree with, if we're talking about healthcare policy, and often these are pretty narrow policies, we can still get to some agreement. Everybody, for example, wants Medicare beneficiaries to have a like max out their value on what they've paid into Medicare for. So if a Medicare beneficiary is not getting what the services that they paid for, left of center, right of center, centrist, it doesn't matter. Everybody wants for Medicare to function well for its beneficiaries because these are folks that they take care of, that they're in their districts, they vote. Maybe it's themselves, they're on Medicare or their family is on Medicare. So it's a federal program. They are charged with making sure it works well. So I just try to keep those things going. I think we're in the 90 plus range, I feel like, of the meetings that I've had that felt productive. And I can write off in my head, that one didn't go so well. Maybe that person needed to eat a Snickers that day. It's fine.
What is a few issues or the one issue in healthcare, that's really bothering you right now, or it's affecting your patients that you want to talk about? I think for me, I've seen a lot of food insecurity. I work with children, so I've seen a lot of food insecurity in the past few weeks. And I've had patients tell me, I've had only one decent meal all of last week, and this is like a real story. So the SNAP cuts really is kind of affecting me. What issue is bothering you right now?
Oh man, there's so much. I would say um, the practice that I've recently joined has a lot more rural healthcare, and the practice I was at in Florida, there were a fair number of rural patients as well, but this one even more so. And seeing how much harder it is to get healthcare services for folks who live rurally, even those who have insurance and other benefits. Things that I took for granted, like ordering home healthcare services to someone's home. It's a lot more difficult the more rural you get. And knowing that because of Medicaid cuts, knowing that other cuts to rural hospitals have been ongoing and continue to accelerate, we're growing more and more of these healthcare deserts, not only in inner city urban populations that are underserved, but also in these deep swaths of rural America. And so there's these healthcare deserts, and there's massive areas that have no maternal health care, for example. It's kind of the canary in the coal mine. It's very difficult to have maternal care networks. And we're creating ER training programs more and more for complex deliveries because there's no provider of OB care in so large a swath of the population. So this is a trend that's been ongoing, rural hospital closure, loss of maternal services. This has been ongoing. It's difficult in our current healthcare system for these hospitals to stay afloat. Now you add Medicaid cuts. This is getting even more challenging, and we're seeing a lot of healthcare systems across the country waving the white flag and saying, we will have to cut services, or we will have to close this hospital, that hospital, this clinic. And the people that live in those areas are having to drive further and further and further to care. Um, and exacerbated and accelerated, I think, by the most recent budget proposal and Medicaid cuts. There was a proposal in this year's budget reconciliation to add some funds for rural hospitals to try to offset some of those cuts. However, it's really not clear to me, just personally looking at it, that the amount that was provided in rural hospital funds, I don't know that that's actually going to offset the amount that will be cut with Medicaid. And the process by which a hospital would have to apply for those funds is also not entirely clear. So it's not a one-to-one, oh, okay, Medicaid was reduced for patient A, but the hospital got this many dollars on trade for patient A's care. It's always harder, I feel, for a hospital to have to go in and apply for a grant or apply for other things to try to provide that care versus just billing Medicaid on behalf of the care for that one patient. So that doesn't mean I think all of it is important. The food insecurity rising, shrinking insurance, reimbursements. People are getting their healthcare premium bills right now for the Affordable Care Act, and a lot of people are going to likely decide to abandon health insurance. That leaves people sicker when they come to care, and then more uninsured care. We're back to, I think, high levels of uninsurance, like what we saw prior to the Affordable Care Act, which was implemented to try to reduce underinsurance. So I'm deeply worried, I think, about kind of all of those things and how our healthcare system grapples with this in a way that provides care reasonably equitably across the U.S., whether you live urban, rural, suburban, whether you're a young female patient who is going to have a baby and lives in a rural area, or you're a child and you're food insecure, or you're an elder and you're aging in place, and we don't have a system ready to care for our seniors who are aging in place and have medical needs, and their adult children may still be working, and there's no one there to provide that care. So there's just so many areas. It's hard to pick one that worries me the most.
Yeah. And when you're talking about Medicaid and the Medicaid cut and the healthcare access to the rural area, I want to, I guess, for you to talk in layman terms, what is the long-term impact of this that you're seeing on your patients and healthcare system? Because if there is a policymaker or somebody who's listening, I just want to know how bad it could be, if you can tell us about that.
Yeah, absolutely. So less access to care, sicker people, longer wait times.
Yeah.
Whether you're talking about cutting Medicaid or people leaving the Affordable Care Act because it's unaffordable, or getting dropped off of insurance in any kind of way. If you don't have access to the health care you need, you're sicker, you're worse off when you get to care. And then that's more strain on our healthcare system. The other thing that I want to bring there is there's an economic driver. So one of the major benefits that was seen in states that expanded Medicaid under the Affordable Care Act was actually a reduction in healthcare related debt. So patients who were in these Medicaid expansion states had less healthcare associated debt. So what the flip of that means is if you don't have insurance, you're not in a Medicaid expansion state, or you don't have insurance and you have healthcare needs, you have more debt. Well, debt is not good for individual consumers. It's harder to buy homes or get or rent a new property or buy your groceries. There's more food insecurity. So it's not just about can I walk in the door and get health care. I mean, the ER is always open, right, via IMTALA. So I can walk in the ER any day and I can get health care if I need ER related health care. But if I then get a bill that I can't afford, now I'm in debt, and that debt is an economic weight. It's a weight on that individual patient and all of the things that they would have done with their money in our economy if they didn't have that debt hanging around their neck. So I would say less access to care equals sicker patients with more debt and more impact on our healthcare system writ large, as well as impact on the economy that's negative.
Yeah. Can you think of, I don't know if you thought of like a patient, like if you had an observation with the patient or a patient experience where you thought, they were having with issues reimbursement or like a prior threat or something that affected them that you can think of as an example in the past few weeks that you worked of the current political climate?
Yeah, prior auth is a huge one. Prior auth itself is a means for insurance companies to control care and control costs. So they use prior auth to try to say, I want an extra review on whatever this doctor or this provider is recommending for this patient. So maybe it's a medication, maybe it's rehab placement or SNF placement, but the insurance company wants an additional way of looking at it. But as a physician, my concern with this is this takes a lot of time. So, as a hospitalist, my patients, I'm trying to turn them around. I'm trying to get them moving through the hospital and out. Hospitals are not great places to be if you don't need to be there, right? We're trying to keep people very safe there, but you could fall in the hospital. You could get an infection in the hospital. So, I'm always trying to say, how can I safely move you out of the hospital? But if I am waiting on prior auth for my patient to go to rehab, say, um, that patient's just stuck in the hospital. I can't safely discharge them, but I'm waiting on their insurance plan to respond to me. Um, I have had insurance plans that said you need to do a peer to peer call, but we don't have any peer to peer calls available for 30 days. Well, obviously, I'm not leaving the patient in the hospital for 30 days. So that's their way of denying that care. And then I'm very likely to just find a new way to manage their care without them going to rehab. I have had, patients have care that I felt was medically indicated that, of course, is denied. This is particularly challenging when they need to go a certain level of rehab care post hospital stay. But it's not clear, it's not published anywhere, it's not transparent. So I am saying I believe the patient needs X. The insurance company says, well, we believe they could get away with Y. And I'm saying, why? Do you want Y? Do you have this published anywhere? Do you have guidelines? Do you have a book? Do you have an algorithm that I could follow? Well, no, no, no. That's all proprietary. Great. But how am I supposed to know that? Because I could have tried to dial it in before calling you and bothering you if I knew what you were going to approve or not approve. We've also seen a lot of insurance companies denying care in things retroactively. So I get a lot of requests for, okay, we had this patient in inpatient status, we discharged them. Insurance company comes back and says, nope, we're going to deny that inpatient stay. We then have to go back and rebill it as observation. This is extra bureaucratic effort, extra work on the admin team. Why this can't just be automatically rebuild as OBS. So the patient was still in the hospital, but there's a lot of extra work there. So, and then there's a lot of just changing of the rules and the kind of rules of engagement between insurance companies and hospitals. So, greater things to move forward in would be greater transparency, greater awareness of how we could engage. If I'm a physician and I know what insurance company A is likely to approve, I can see if that fits my patient. And then if it doesn't fit my patient, I can be ready for the appeal and ready to fight on behalf of my patient, which is advocacy. But I have to know what it is that they're looking for and then how it is that I'm going to move forward. So prior auth, it's, I think, more of a scourge for my outpatient colleagues because they have to do a lot of prior auths for medications. Thankfully, in the hospital, we don't have quite so many prior auths for medications. Although I did have one of my colleagues sent a patient home on a long-acting form of insulin, and there's a couple out there. And so he wrote a prescription for this long-acting insulin, sent it to a pharmacy of the patient's choosing, which was several hours away. The patient discharges, drives out to that pharmacy several hours away, and then they're told that the prescription's not there. And it was because it went into a prior auth status. And of course, it being after hours, the patient couldn't get their insulin, and they had to make do with some kind of substitute insulin that they purchased over the counter at an institution that does that. And so it nearly led to a readmission. It was obviously very distressing for everyone involved that the patient didn't get their insulin, and the provider team had no idea that this particular insulin was prior auth because we'd all used it for years. So suddenly it's on a prior auth status. Why? Um, and it's just delay. It was just a delay in care of getting the patient their insulin that was just really mind-boggling.
Yeah. Does it cause you moral injury, seeing all this around it, just not being able to provide the care that you want to provide? And have you seen it in your peers and colleagues, Tell me more about that.
Yeah, I think moral injury is a good way of putting it. We're all facing tighter turnaround time. If you're in the hospital, we're trying to push patients through the hospital faster. I say very frequently that hospitals are no longer places to recuperate after acute illness. Hospitals have really become acute diagnostic resuscitation centers. Once you have met all of those criteria, then often we are pushing people into the post-acute space, be that rehab or skilled nursing facility or home with or without home health services. Larger burden on families who are trying to provide that care for patients in their homes. And that could be a medically complex child, it could be an aging senior parent, or even just a sick family member. More and more care is being pushed into what we call the outpatient space, but a lot of that is truly families. And so I have gotten skilled at having very difficult conversations about why I am pushing to discharge this person who doesn't feel good. And I am having to tell them that, well, according to, your insurance or Medicare or whatever rules, you no longer meet criteria to be in the hospital. And we need to go ahead and proceed with getting you to the next level of your care. And I know you don't feel good. And here are the things that we can try to do to get you feeling better and recovery at home. But the hospital is no longer a place really to recover. And so just because it is something that I have developed a skill around doesn't mean it is something I necessarily enjoy. And certainly I have had patients that get very distressed and beg and cry, and that feels terrible. It really feels terrible to have to feel like I am pushing someone out because of a payer issue rather than because of what I may or may not believe is right for the patient.
How distressing is that? Oh, gosh.
Yeah, it's pretty terrible. I mean, I do my best to try to be sure the patient is actually medically ready. Maybe I should backtrack on that. Like, that there really isn't anything else that I could do in the hospital to keep them there.
Yeah.
But it's so hard.
Yeah. Yeah. But I mean, still, sometimes they need more time to get out of there. And we're not able to provide that. With the holidays coming up, do you have any thoughts on like the SNAP cuts and the food insecurity piece? Have you been following the news on that?
Oh yeah. Yeah. I've been donating to my local food banks, seeing a lot of activity in, Facebook groups, like Buy Nothing groups, groups where people will volunteer to meet up with folks that, hey, I had somebody come to my home and take some canned goods that I had in excess. Um, I had somebody else who wanted those canned goods that I wasn't, I had already given them away. And so I met them and gave them a grocery gift card. Um, just these little tiny actions that maybe help me feel like I've helped someone, even though I feel kind of powerless in the face of the larger SNAP cut issue. Um, I'm hopeful that those will come back either via one of the court cases that's wending its way through, or of course if the government is reopened soon. But how horrible that we are in this position that funding for a program that I don't believe has ever been cut before in a government shutdown was cut during this one. And in a way where people had no time to prepare. And folks who use SNAP are by definition going to have the least ability to prepare because you have to meet the income requirements to get SNAP, right? So you don't have a cushion, you don't have a nest egg. You're living paycheck to paycheck. There is no ability to prepare. The whole situation is very cruel. It's distressing to watch. I am a blessed person with a lot of privilege and a lot of resources, so I do what I feel I can to try to help support my local community. Um, it doesn't feel like it's enough, uh, but just trying to stay aware and trying to do the things that I feel like I can help people. Um, that's all I got. I don't know how are you handling that in the pediatric space where you're seeing these kids coming in and food insecure? That's so heartbreaking.
Yeah, and I mean, I know that's what I was gonna say. I've had few patients tell me, and I was like, I may have been naive and asked them why you haven't had a meal in a week, and said something to me like, "Haven't you looked at the news, or haven't you heard about the news?" And I guess my question came from like what I could do to help. But when the problem was presented to me, I really thought, I don't know. And then I started scrolling the local food banks and shelters to see what could help them. But w- it just I feel so much guilt, of seeing these patients and families and not being able to provide them, that they are not getting what they need and they deserve. And if they get affected, if they don't have, their children get affected. And yeah, what a shame. I just say what a shame.
Yeah, there's not enough words around it, but it's yeah. Guilt, I think, is a good way of putting it. Not that, different people are at different parts of their life, but it's there were times when I was growing up where money was really tight in my family, and I don't think we ever had to go on SNAP, but things were close. And I always kind of look at it as that could be me in an alternate world, or that was almost us as children, and and so I just try to keep that in mind. There's a lot of judgment out there about people using SNAP, and no, I just think we as a society, we should be better than that, and people should not be hungry. Children should not be hungry. I moved to a state recently that offers school lunch and breakfast for all students in the state, and it's tremendous. It's wonderful. Kids learn when they're fed. Why would we ever accept a consequence of saying, well, kids shouldn't get to eat, when we know the outsized impact that has on their overall health, their well-being, their learning? If we're all worried about our education system and our children's learning, I mean, number 1, 2, and 3 is making sure they've fed.
Yeah. Yeah. Well, I just hope by the time this podcast is released, things are better. But
Same.
in a few weeks, yeah.
And regardless
Yeah.
of what happens with everything, I will continue donating to the food pantries in my local area, because there's always need, regardless of this acute crisis. But there is a crisis right now, so anything that anybody can do to help, please do.
Yeah, I mean, I think I've seen it more than I've ever seen it before. So I think it's like lifting up a lot of issues that were already existing in the
Yeah.
past. But yeah. Um, Pivoting a little bit, but how do you feel about physicians, advocating for themselves? I think you're talking about a lot of moral injury, burnout, and you've worked in patient safety space too, and you still do. How do you feel about advocating for like hospital staffing, malpractice reform? Have you ever gone in that space or no?
Yeah, one thing that has come up in the last few years as a hot topic is workplace violence and staff safety. So, was just on a call discussing this earlier today. So, my analogy on that is during COVID, it was very obvious that staff safety equaled patient safety. If my staff were exposed to COVID, got sick, went out, on leave to stay home, then that's one to one. That's somebody who's not there to provide patient care, right? So, staff safety was very obvious and visual that staff safety was patient safety. Then, as workplace violence, I think, has come to greater attention, I view it in the same kind of space that if one of my staff is the victim of violence, either verbal or physical, then they're not able, it impacts their well-being. They're not able to provide care to their patients. They may have to take time off. They may have disability. They may have PTSD and trauma. That's just a horrible thing to try to encounter writ large. So one thing that I had done in my previous work with quality and safety was to try to firmly put myself and the patient safety and quality movement at my hospital into that space and advocate for what some people have called safety without adjectives. So meaning that patient safety is staff safety, that these are safety is a big global term. Um, and so trying to make sure that when our staff were saying things in surveys like that they didn't feel safe or that they were, had been assaulted or that they had not had anyone to tell when these things were happening, trying to be part of that movement to try to help. And thankfully, when you go into advocacy, you feel like you're alone until you realize there's a lot of other people a lot of times in these spaces. And so joining with people who felt the same way as I did and seeing the things they were already doing to try to improve staff safety. So it wasn't my project. What I felt was important was to elevate to them the voices of staff that were asking for help, and then to take back from these projects back to staff and say, we are hearing you. Here are the things we are working on. You are asking for these specific tactics. And guess what? We are working on that. You're asking for different strategies to try to help. And so sometimes the advocacy is to try to fix the thing yourself. I found a group that was already working on it. So then the advocacy to me becomes, let's talk to the people who are suffering and let them know that we're hearing them and that we are trying to work on it and do a little bit of PR, if you will, around some of the things that we were doing to try to help. So staffing is such a hard one. I haven't had to really dive into that one, but I feel like it's going to be a growing topic. I think Joint Commission is going to really start looking at staffing. We're seeing some state house level bills popping up here and there, trying to mandate nursing staffing, for example. We're seeing some little pop-ups here and there across the country related to physician unionization. I think this is going to be a very interesting space to keep an eye on the staffing questions, both for physicians and healthcare providers, as well as for nursing.
Yeah. And I was going to say, when we were talking about healthcare workers, one of the issue that I think of that also impacts healthcare access to rural healthcare is, the visas and, the money that they have. So these are the physicians who are working in those rural areas that you're talking about. And then the visa requirement, it's like a big question mark. The money clause, I think it was like $100,000 money clause. It's going to be a big thing. I think it's affecting physicians and it's affecting the healthcare that we provide in those rural areas. So, yeah.
Oh, absolutely. So you've got, in my mind, kind of two main branches of that question. You've got your folks that are already on H-1B, who many times are left without a path to green card or citizenship, depending on where they're from, some of the specifics around the H-1B program. And in my mind, part of the problem is that the H-1B program is not specific to physicians. Physicians, I believe, only make up a very small percentage of the overall H-1B population. So this H-1B visa fee that that's getting added, I think physicians are kind of swept up in this, even though it seems like the actual thing that is being addressed by the administration is around the tech industry. But physicians are in there, and there's certainly not to date yet been any removal or exemption for physicians. The AMA and 50 plus healthcare organizations signed a letter asking for physicians to be exempted. The American Hospital Association has also asked for physicians to be exempted. It has not happened yet. So you have the new H-1B visa people coming in with this new fee. So that's going to greatly restrict hospitals' ability to hire on H-1B. And then you also have the people who are already on H-1B who are unable to have a path to citizenship in some cases, depending again on what country they're from. And so their lives, they may have a steady feeling job. Many times they have families here. Many times they have children who are American citizens. But it still feels impermanent. when I've talked to some of those physicians, that still feels like their employment is really kind of tying their ability to be here in this country, and that it doesn't feel permanent and safe and secure. So there's advocacy right now around the H-1B $100,000 fee for physicians, trying to exempt physicians. And then there's also advocacy around what could be done differently in terms of the physicians already here on H-1B without really a clear path to citizenship. Um, and so I know a lot of groups kind of looking at that. I think it's really ripe for reform. Um, and then some people will ask then, well, why then are we advocating only for physicians who trained internationally? Are we doing anything to grow our local supply, if you will, our national supply here in the US? And I think it's an important piece of the coin. Um, it's just a thing that takes a long time. So there are increasing medical schools across the US. Um, we do need to do some work on trying to right size our GME component, our residency slot component, to be sure we're adding slots to match where those students are. I think we need to incentivize students to go into primary care fields, because we do have many open slots every year in primary care fields, in internal medicine, family medicine. Across the country, these are residency slots that go unfilled. And oftentimes then folks who train internationally do apply and come in for those, because those are jobs. Those are jobs that are open that we were not able in the US to fill with American grads from American med schools. So I think there's a lot of things that we need to do to try to improve the pipeline, while also making sure that if we are currently enjoying the healthcare provision of the best international graduates who want to come to the US and practice here and take care of our patients, often in the most rural and underserved areas, and there's a mismatch in supply and demand in American medical grads, then I think we need to do both things. We need to increase our supply of American trainees, and we need to continue to recruit and retain the best and brightest of the international physicians who want to come here and be part of our community in the US. And I think we can do both at the same time.
Yeah, and I mean, you said a very important point that a lot of them, because of their visa requirement, are filling those spots in the rural and underserved areas, which perhaps the American graduates do not want to take, for being closer to family. And this is a fact, that they do take up those spots. Are you pretty sure the exemption hasn't been waived for physicians yet? Not yet. Yeah.
It had not as of the last time I had looked.
Okay. I'm not sure either, but yeah, I haven't heard either. So I was curious. What, for someone listening who's interested, but kind of feeling overwhelmed, what's a small first practical step I think they can take today to start engaging in advocacy?
That's a great question. I think a small first step would be, I'm assuming that we're talking to folks who are in healthcare. So I would say the first step is to look at the specialty society for whatever your field of healthcare is, and see what news they have and what action items they have on their website that you can take part in. So groups like the ones that I'm a member of. So again, not speaking on their behalf, but Society of Hospital Medicine, Society of General Internal Medicine, American College of Physicians. All of them have websites where they have areas for advocacy. They'll have news briefs. They'll have advocacy actions. You can sign up for alerts via your email. A lot of times there's email actions that you can take through the website or get signed up for their alerts. It's so easy. You click a couple links. It helps you set up an email that's already templated. You can always edit if you want to add a little personal story. And then that email is going to go to the offices of, if it's federal, it's going to go to your representative and your senators. So you're generally generating 3 emails depending on the action item itself. And you can add little stories. Again, physicians were storytellers. So putting your story on there is going to be really important. So it's so easy. We send emails all day long. So logging in to the website of your specialty society and finding out what action items and what action alerts that they have right now, and taking that first little quick action, super helpful. So I know the American Academy of Pediatrics does a lot of this work. If you're an OB-GYN, ACOG does a lot of this work. Again, just find your specialty society, go to their website, find the link, click it, send that first email. And if that's as far as you go, you still took action. That's amazing. And if you want to go further, a lot of times those specialty societies have those hill days, they have training programs. I attended a specific training program through one of my societies, taught me a lot. Highly recommend getting a little extra training in this if you've got the bug. Once I got the bug, I needed more training. I got it. And then I kept going. So and then if you can't, if you just can't, if you're so burned out and you're so exhausted from your day to day and you think, gosh, I just can't even send that email. I can't go to the website. The news is overwhelming me. Um, Advocate for an individual patient, then making sure that they get what they need, or donate to your local food bank. Check in with your fellow staff members and see if there's something that staff need on the local level. So all advocacy is important. Local action is really important. Don't feel like you have to go all the way as far as taking a trip to Washington, D.C. and meeting with lawmakers, that's the only action you can have. In fact, a lot of times, local action is going to have an even further reaching impact than maybe taking that Hill Day trip. So it's all important. And I would say do the thing that you feel capable of doing. I would just start with that.
Yeah, I love that. We're almost going towards the end. I think I have one or two last questions before we finish. Do you see a certain risk for being like political or when you have to take a side as a physician, and how do you balance that?
Yeah, I think there's always risks, right? The First Amendment protects us from the government criminalizing our speech. It does not protect us from the potential consequences of our speech. It doesn't protect me from somebody not liking something that I said, et cetera. So I think just being thoughtful about the way that you use your voice. If social media is your thing, great. Use your voice on social media. Be sure, though, that if your healthcare organization that you work for has media policies, that you read those policies. If you violate those policies, they have actions that they can take. You could be subject to disciplinary action. So just be sure that you have read those policies and that you're aware of the consequences if you violate those policies. Also, be thoughtful about the fact that things that go on social media are really not private. And, even if you think you're in a private group or private space, there could be somebody who takes the things that you say out of context, could send it to your employer. Just be thoughtful about it. You can use programs out there. There's commercially available programs or programs on things like Doximity that many of us are signed up for if you're a physician. But there are programs out there to help remove your personal information from the internet. It's not a bad idea, regardless of whether you're in advocacy or not, to try to be sure that it's not easy to get a hold of, let's say, your address or your cell phone number. So check those out. I'm not trying to sponsor, I'm not sponsored by any of these programs. I'm not trying to advocate for any particular one or the other. Just take a look at what you can do to protect yourself online. If you do engage in the media, if you do media work, again, check with your organization of what their policies are. Try to make sure that whatever you're doing, it feels right to you, as well as that you're aware of any potential consequences, again, if you were to violate a policy. So, but beyond all of that, if you feel it's important to say something, then you should say something. When I post on social media or I talk to others, I try to make it clear when something is my opinion and when it's not. Um, when it's really important, though, I'm going to say something, even if it's coming down on one side of a political opinion, because guess what? Everybody has political opinions. The last thing I would say is I do try to keep it around the policy and not the person or people. And I try to make it where if I wrote something on the internet and it was read out loud in front of my boss the next day, that I wouldn't be absolutely dead of embarrassment for whatever I wrote. So it may, and now I'm 43, so I'm a lot more experienced in kind of holding my tongue on things than I used to be. If something feels important to say and I want to take an opinion on a policy, I will take that opinion. But I try not to use curse words. For example, I try not to say, well, that group of people is so terrible, things like that. I try to make it around this policy and my opinion on it. your mileage may vary. You will have different thoughts and opinions about it. But do be thoughtful about what the particular policies are of your organization and then know how far you are or aren't willing to go.
Awesome. I think the last thing I'm going to say is, we talked about a lot of sort of depressing, dismal things too in today's podcast. What gives you hope for the future?
Oh, I think just thinking through that, the generations coming up after us, younger than us, are watching what we're doing. They're watching what our system is doing and thinking about ways that they want to make things different. And so I'm always hopeful that we'll come out in, a few years, we'll come out with something better than what we have, more equitable, more just. I watch how my kids talk about the world, and they are really strongly passionate about, justice and fairness, and they're not that, they're still pretty little. They're at elementary school. So I just have to be hopeful that whatever we're looking for now, whatever we're trying to fight for now, that the folks that come behind us will do an even better job.
Yeah, I love that. Thank you so much for being and doing this with us today. And I think we talked about some really, really important things. And I really appreciate your input, being up in the space. And I think we all need to kind of follow your lead and try to do what you're doing as well. We have a tradition on this podcast, and we ended with a poem. So if you'll stay with me for that, just talking about advocacy, it's the language of hope. And as we close, I'm reminded of the world we all want to build. And it's a poem by Langston Hughes. You may have heard of it. It's called I Dream a World. I dream a world where man, no other man, will scorn, where love will bless the earth and peace its paths adorn. I dream a world where all will know sweet freedom's way, where greed no longer saps the soul, nor avarice blights our day. A world I dream where black or white, whatever race you be, will share the bounties of the earth, and every man is free. Where wretchedness will hang its head, and joy, like a pearl, attends the needs of all mankind. Of such I dream my world. Thank you so much, Dr. Cowart, for doing this with us today.
Thank you, Dr. Fatma.